Welcome to Nervous Breakdowns, people. On today's show, we discuss bipolar disorder. I talk about how it's diagnosed, about the fact that more and more people are claiming to have it, and why I personally think the diagnosis is overused. Join me, won't you?
You're listening to Nervous Breakdowns, a podcast where your questions about relationships, dating, personality, and mental health are answered by Gino Tramontelli, a nationally certified counselor with a master's degree in clinical and counseling psychology. Here's the man himself, Gino Tramontelli.
Welcome back, everyone. Nervous Breakdowns with G, the podcast where we discuss all kinds of mental health topics. And on this episode, we're going to be tackling bipolar disorder. Now, because of the nature of my topic today, I'm just going to give you some of my resources up front. If you think you have a mental illness and you're looking for treatment, please visit samhsa.gov. That's SAMHSA.gov. It's a great starting point for mental health treatment. You can find a provider in your area. If you live in Central Jersey, and you want to come and visit me at my practice, or the practice where I work, rather, you can try me at BeWellNewJersey.com, BeWellNJ. It's a great private practice. They accept most insurances. And if you have health insurance, you can always call your insurance provider and they'll tell you who accepts it in your neighborhood. If you have questions for me in particular, you can reach me at, you can follow me on Twitter at BreakdownsWithG. You can email me, breakdownswithg@gmail.com. You can check out my Tumblr page, breakdownswithg.tumblr.com. Just check me out. I definitely rely on your feedback, on your questions, and the more you can give me feedback, the better a show I can make for you. So today we are talking about bipolar disorder. Working in a community mental health center, and particularly in a crisis setting, we see a lot of people who come in for various reasons. You know, they're not happy, they're having some distress, and they tell us basically as soon as they sit down that I think I'm bipolar. And, very often we have to explore that with the people. We have to say, well, what makes you think you're bipolar? Why would you say such a thing? Have you been diagnosed this way? Did you have another doctor that tells you you're bipolar? And inevitably it's one of a few reasons. Well, 1 minute I'm fine and another minute I'm not. 1 minute I could be happy and another minute I'm crying. 1 minute I could be sad and the next minute I'm throwing things around my apartment. And it's essentially people that are having complaints about erratic behavior. Their behavior changes, or what we would call labile. It changes from one moment to the next. Another thing that they'll claim as bipolar is just making bad choices. I did something stupid, or I can't seem to keep friends, or I got fired from my job. I have to be bipolar. And when we hear this, it's very difficult to maintain an objective standpoint, because and I hope that most professionals aren't doing this, but it's hard when you hear a diagnosis not to start to think that way. And I think it's important where if you're trying to get treatment, you talk about the symptoms that you're having and don't offer a diagnosis right away, because sometimes a clinician who is not having a good day or maybe isn't as competent as somebody else may just accept your diagnosis and work from there. And I think in order to understand why that happens, I need to first get into some details about how psychiatric diagnoses are treated or handled differently or arrived at differently than other kinds of medical diagnoses. So I think this show might be a little bit inside, but I'm hoping that I can make it interesting for a lay person or somebody who just is interested in mental health. So when you seek medical treatment, let's say you are playing basketball with your buddy and you turn your knee funny and you start to have pain, you go to your doctor and you tell your doctor, hey, I was fooling around, I was playing a pickup game of basketball with my friend, my knee hurts now, I think I twisted it. And your doctor will ask you your symptoms. Okay, what does it feel like? Does it hurt when you do this? Does it hurt when you do that? Okay? And using that interview, the doctor will then make some decisions about what kind of tests need to be run. he may send you for an MRI, right? He may say, oh, you seem to have hurt yourself pretty good. I want to take a look at what's going on inside your knee. Let's go get you an MRI done. Or he may say, what you're describing sounds like you tweaked it a little bit, but I don't see any reason to think that there might be some damage inside. So just give it a week and then tell me how you feel. But if he sends you for the MRI, he's going to get a very clear picture of what happened. He'll look inside your knee and he'll say, yep, it looks like you tore your meniscus, or it looks like you have a ligament tear, or a tendon is messed up. And from there, from making an accurate diagnosis of the root of the problem, he can prescribe a treatment. So he'll say, okay, well, this is torn. We could try some physical therapy and see if we can strengthen the knee or make it work better, and hopefully that'll make some of your pain go away. Here's a medication for pain or inflammation, or we got to do surgery. We got to go in there and repair the damage. The doctor, by using a system of questions and tests, can make a very accurate diagnosis of what is the cause of the problem and then take steps to attack that directly. Okay? Same thing with other medical problems. You have, you go to your doctor, say, hey, doc, if I do even just a little bit of exercise, I find myself short of breath. I have tightness in my chest. The doctor will run some blood tests, may take a look at your heart and say, okay, look, you have a blockage in one of your arteries. Your artery is full of all the gunk you've been eating for all these years. We have to do a heart a bypass surgery or a double bypass, or your valve isn't working properly. It's not letting the blood flow the way it needs to flow. We need to replace that valve or repair it. Again, the doctor can look at the problem in a very concrete way, diagnose it, identify the root of the problem, and suggest treatments, within the realm of what's medically possible, right? I mean, certain illnesses, there just aren't cures for. If you have HIV, you go to the doctor, they have medicines that treat it and treat it quite effectively, and we keep hearing news that there are cures. But the doctor will, from a blood test, know exactly what the virus is that you have and be able to take it from there. Okay, so now giving you traditional medicine, now let's talk about psychiatric medicine. Psychiatric medicine is a little bit different than that, in the sense that we don't have the capacity to give somebody a test or a CAT scan or an MRI and to see what the actual problem is. The brain scan of somebody with like a CAT scan of somebody with depression doesn't look different than somebody with bipolar or anxiety or any other illness. Except in some rare cases, there's some evidence that in people that suffer a certain illness over a long time that go untreated, there's actually some changes to the brain structure. But my core point remains is that even if that wasn't the case, that as a mental health practitioner, we don't have the benefit of a really concrete diagnostic tool. And so what we have to do is do a very good and complete and thorough diagnostic interview, which is what we call a core assessment or intake. It's when we sit down with somebody for the first time and we try to get a sense for what brings them to our office. Which is also why, if you're ever going to mental health treatment, your first appointment will usually be a little longer and a little more costly, and you may also see more of your treatment team on the same day. For example, when people come to see us, they see our prescriber, myself, the counselor, and our case managers. The first appointment can be a lengthy one. So what we do is we conduct this very thorough interview. We try to get a very clear picture of what the symptoms are, and then using what we call the DSM-5, the Diagnostic and Statistical Manual of Mental Illnesses, version 5 just came out last year, so we're trying to stay up to date. We use these clusters of symptoms to try to identify a diagnosis. And sometimes it can be tricky because symptoms can mimic each other. Now, I want to point this out, is that this is why it's very important not to try to diagnose a mental illness from, if you have no training. I mean, if you can go on, for example, WebMD and find all the criteria for any psychiatric illness you can imagine. You can find them all, from antisocial personality disorder to depression to schizophrenia to dissociative identity. You can find them all. But where it's tricky and where the training and expertise comes in, and even experience, because in my 10th and 11th and 12th years of practice where I am now, my clinical judgment is vastly superior than what it was when I first started. I can get a sense. I can identify nuances in people's psychiatric presentation now with much better accuracy than I used to be able to. But what happens is symptoms can be similar. And I want to talk about bipolar disorder today, and we're going to actually go through quite specifically what the symptoms are. And I'm going to share with you another illness that can seem really similar, but the treatment is actually the opposite. The treatment is quite different. So let's just take a look. I have my materials. I did my homework here, and I'm looking at the criteria for bipolar disorder as listed in the DSM-5. So essentially, for a diagnosis of bipolar disorder, somebody has to have had a manic episode at some point in their life. It could be just once, but the manic episode has to have been present. And what a manic episode is, I'm reading here, it's a distinct period of abnormally and persistently elevated, expansive, or irritable mood, goal-directed activity, or energy, elevated energy, lasting at least 1 week and present most of the day, nearly every day. Okay, so I just want to be clear. They have identified the length of the episode. There has to be at least a week and most of the day, all day. And during this time, somebody's going to be feeling grandiose. They're going to be irritable. They're going to be very energetic, doing lots of things. And now, during that time, 3 or more of the following things have to occur. For example, 1, feeling inflated self-esteem or grandiosity. They think that they're better than everybody else, that they're special, and sometimes these things can be religiously preoccupied where they think that they're a prophet or Jesus. During the time, the second thing is they don't need to sleep very much. In other words, it's not like I can't sleep, but I feel tired. Like I slept 2 hours and I feel like that's all I need. I feel like the Energizer Bunny. The person is more talkative than usual. That's the third one, that they just kind of feel this pressured, rapid, like I can't get the words out fast enough. The fourth one is flight of ideas. So you're feeling that my thoughts are racing, feeling distracted. In other words, I'm sitting here doing this thing and my mind goes to the next topic. I leave this thing halfway done. I move to the next one. The goal-directed activity, as I described, where just kind of you're purposeless or running around and just doing a lot of things but not getting anything done. And then in being excessively involved in activities that have a high potential for painful consequence. So in other words, going on spending sprees, gambling, being promiscuous, investing in a business that's going to fail. Now, these things, 3 of those things I just described have to be present. They have to disturb the person's function. So, in other words, they're not going to work, or they're screwing up their relationships, or failing out of school because of it. And they're not due to a drug being present. So, in other words, the person is not high. So, what we've described is these are the criteria that I'm looking for. As I'm listening to somebody and they're talking to me, I'm listening to their reports, and they're telling me, I haven't slept, but I don't really feel like I need to sleep. I'm listening to the way their speech is coming out. Do they feel like they're machine gunning their speech out, like ta 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 ta? I'm listening for that. I'm listening for their attitude about themselves, if they're talking like they're special or they're better than other people, and just trying to get a sense for whether or not this is impacting them. I also, and very often in my first time meeting with somebody, I'll ask them to give me a urine sample so I can see if they've been high or if they're not being honest with me about their drug use. Now, so this is one criteria for bipolar disorder. It's very specific. You have to meet this criteria or you don't qualify. There's also the other part of bipolar. Bipolar used to be called manic depression in the old days, and the other part of it is that you feel depressed. So when you're not this way, you're going to have depressive episodes, and I'm not going to go through those. I mean, that's pretty straightforward, but it's the same idea. It's here's 12 different symptoms. In order to qualify for depression, you have to have 6 or 7 of them. Actually, it's 9, and you have to have 5. I'm just looking here. I printed this thing out, so I might as well be accurate. And there's also bipolar disorder 2, in which you don't fully qualify for a manic episode, but you qualify for a hypomanic episode, which is a little less intense, but still kind of the same types of symptoms. And so when we see somebody with bipolar and they describe, oh, my mood changes from 1 minute to the next, that's not really what's being described in bipolar disorder. Even something called like rapid cycling bipolar, which is something that we see sometimes, I looked that up because I was curious about the actual diagnostic criteria for that. And a rapid cycling bipolar means that they have 4 episodes a year, but not from moment to moment. You know, you're not you're not manic this minute and depressed the next. When you're having this manic episode, it still lasts the whole week, up to a week, and then goes away and then comes back and goes away and comes back 4 times a year. So every 3rd month, let's say. So just to be clear, when you see somebody describing somebody else as bipolar, they in order for them to qualify for that diagnosis, they really need to meet these very specific criteria. Now, bipolar disorder is an illness that's almost 100% organic, meaning it's almost 100% having to do with your brain chemistry, and it responds pretty decently to medication. So people that take mood stabilizers like lithium, for example, or Depakote will typically find that their mood doesn't have the range it might have once had. If we consider mania a high peak and depression a low valley, it'll kind of smooth out those spiky jags in your mood level, and you'll have more of a, your mood may not be as stable as the average person's, but it won't be to the extremes where it disturbs your function. And the primary treatment modality for bipolar disorder is, in fact, taking medication. Now, that doesn't mean that counseling doesn't help. In fact, counseling is pretty essential also. It's just not the primary mechanism of change. What you're going to do in counseling is work on people, their acceptance of the illness, educating them to be mindful about their symptoms, to be aware when they're having a problem that's related to their illness, and to make good choices about their treatment. In mental health, particularly with a serious illness like bipolar disorder, what we try to avoid is these weird cycles of increasing function when somebody's getting treatment, and then a plummet. Because what often happens is people that get treatment for psychiatric illnesses tend not to be that happy about it. I mean, they tend not to really be that excited about the fact that they have to go see a doctor and take medication and feel like a crazy person. So what happens is they take their medications, they start to feel better, and they say, okay, I don't need this medication anymore. But in the meanwhile, while they've been getting better, they might have found a job, they might have started a new relationship. They come off their medication. It takes the medication a little while to get out of your system. And then within a month or 2, they're starting to have symptoms again, and then their function plummets. So just like their symptoms, they have a spike up of I'm doing much better, come off the medications, drop out of treatment, and within a month or 2, boom, they've lost a job, the girlfriend leaves them, you name it, maybe they've gone back on drugs and alcohol. So what we try to do is to increase education, increase motivation for treatment, and just help people understand that in order to keep your success going, you have to stay in the treatment. Now, another thing about bipolar disorder is that in most cases, it's not curable. What happens is you have a dysfunction if you have bipolar in terms of the regulation of your brain chemicals, where sometimes your happy chemicals are going too hard and too fast, and sometimes your depressed chemicals are going too hard and too fast. And there's not a lot we can do in terms of, like the doctor who fixes your knee, who goes in there and actually repairs the damage. We're not even really sure what the mechanism is. There's still a lot about mental health, mental illnesses that we don't fully understand. So we think of this illness as more of something that can be managed, like diabetes. If you have diabetes and you need to take insulin, you better just get used to it, because you're going to be taking insulin for a while, forever, basically, until they can cure the problem. It's this way, too, with bipolar disorders. You're going to be on medications essentially until, forever. I mean, that's the short story. Now, I'm sure you can go online and find some people that have cured their bipolar disorder, but I suggest and I suspect that the people didn't really suffer from bipolar disorder. And in fact, I'm going to share with you another illness right now that looks functionally identical. And this is called borderline personality disorder. Now, I'm going to read the diagnostic criteria, and I'm going to, well, first of all, let me talk about what a person, how can I proceed? Let me read the criteria, and then I'll talk about what a personality disorder is, okay? So the criteria are these. There's 9 of them. So it's a pervasive pattern of instability of interpersonal relationships, self-image, and affects, marked impulsivity, beginning in early adulthood, and present in a variety of contexts, indicated by 5 or more of the following. Okay, so these 5 of these following 9 things have to be present. 1, frantic efforts to avoid real or imagined abandonment. Okay. 2, a pattern of unstable and intense interpersonal relationships characterized by alternating between extremes of idealization and devaluation. All right, so what does that mean? Meaning, if you ever knew somebody who always had a new best friend, every time you met them, oh, that's my best friend. What happened to the last best friend? Oh, they suck. They're a person who, their relationships are either, the person is either the best person they ever known, they put them on a pedestal, or they're the worst piece of garbage ever. That's what this is talking about, that this pattern persists throughout their lives. If you do everything perfectly and accurately to me, I love you the most. And if you do one bad thing to me, you're the worst piece of garbage on the planet. So that's the second one. 3, identity disturbance, meaning really unstable ideas about self-image or your sense of self. 4, impulsivity in at least 2 areas that are self-damaging. For example, spending, sex, substance abuse, reckless driving, binge eating. Okay? Now, I want to remind you, wasn't that one of the things in mania? Sure. I mean, that was definitely one of the things that we talked about in mania. 5, recurrent suicidal behavior, gestures or threats, self-mutilating behavior. All right? Somebody that cuts themselves, that burns themselves. In bipolar disorder, during the depressive episodes, we can see sometimes depression. We can see suicidal thoughts. Okay? 6, affective instability due to marked reactivity of mood. All right. So affective instability means like unstable mood and unstable presentation. So when we talk about affect, we're talking about what we can see: the crying, the smiling, the outward looks of the mood. So we'll tend to see, for example, intense sadness in a person with borderline personality disorder, or irritability or anxiety that lasts a few hours and rarely more than a few days. Okay, again, sounds like mania a little bit, right? It's this kind of mood swinginess that can last 1 minute they're fine and 1 minute they're not. And I felt depressed for a few days and then it went away. All right. Number 7, chronic feelings of emptiness. Number 8, inappropriate, intense anger, irritability, difficulty controlling anger. So frequently acting out, smashing things in their house, getting into fights. All right. And number 9, transient stress-related paranoid ideation or severe dissociative symptoms. So this is one we see less commonly, but feeling paranoid, like other people are out to get them. All right. Now, it may be difficult to see, because I'm reading it to you, but when you look at it down on paper, there's a lot of overlap here. There's a lot of overlap. In fact, if you looked at it at a glance, it would be difficult to tell the difference between these 2 illnesses. But interestingly enough, this illness, the borderline personality disorder, doesn't respond to medication because it's not the product of an organic problem. It's not, your brain is not misfunctioning. Okay? What a personality disorder is you have, in some of my past episodes, I've talked about these automatic thoughts that we can sometimes develop, like the idea that if I let go of something that I'm holding out at arm's length, that it's going to fall to the ground. I don't need to think that. I know that from experience, that when gravity acts on things on this planet, and when I drop something, it's going to fall to the ground. So that's an automatic thought for me. Well, in personality disorders, there's usually some automatic thought that is driving all these behaviors. For borderline, it's one of 2 things. They're really related. It's the first, that everybody in my life is going to abandon me. So that's one. But underlying that is the second one, which is that I'm worthless. And can you imagine what your behavior might be like if you thought that you were worthless, and because you're worthless, everybody in your life is going to abandon you? All right? You would have the same type of going back to the relationship stuff. The person's either the best or the worst, right? If I'm worthless and everybody in my life abandons me, and somebody does a nice thing for me, I'm going to really think that they're really cool, right? Like they're essentially, wow, I can't believe this person. They must be the greatest person ever if they've done such a nice thing, if they've shown kindness to somebody as worthless as me, right? But then the minute they do something that I don't perceive, or I perceive as either not nice or against me, well, the opposite is going to happen, right? Whoa. What a piece of garbage you are, right? You're just going to abandon me anyway. I should have known better. I hate you. So we see that this is an illness that doesn't really respond well to medication because it's not medically based. It's cognitively based. It's based, and it's based in a way that's really kind of in the core of the person. The person doesn't think about, I'm worthless and people are going to abandon me. They just kind of react emotionally to the things that people do to them because they're seeing everything through that filter. People with borderline personality disorder also often feel depressed, right? If I don't have relationships that are meaningful and I feel empty inside all the time, and I think that everybody in my life is going to hurt me or abandon me, how could you not feel depressed? So what we're seeing here is a ton of overlap and sometimes a difficult diagnosis to make, and two wildly different treatments, right? In borderline personality disorder, the main treatment is going to be tons of intensive therapy, lifelong therapy, because you're trying to counteract a belief system that's really, A, under the surface, the person's not even thinking about it, and B, at the very core of that person, how do you convince somebody who thinks they're worthless without even thinking about it that they're not worthless? I mean, it's not going to be a session or two. You're going to have to really work with the person. If you give medication, it's in conjunction to the therapy. If somebody's depressed and they're crying a lot because of the relationship stuff, like I mentioned, they may benefit from an antidepressant, right? Now, if you give an antidepressant to a bipolar person, you're going to kick them into mania, okay? So I just want to point out that the diagnostic thing, or diagnosing people in psychiatry, is very difficult, and in counseling and mental health, it's difficult because some of the symptoms can overlap. Now, let me throw another third one in. Drugs, okay? When people are in withdrawal from several kinds of drugs, or even under the influence of drugs, it mimics psychiatric symptoms, all right? Let me describe somebody. Somebody goes out with their friends at night. They use a little cocaine. Right? Next thing you know, they're not sleeping, right? They're not going to sleep all that night. They're going to do all kinds of wild stuff. They may have a bunch of sex, right? Spend all their money. The next morning they wake up. They feel like crap. They feel depressed. They feel anxious, right? Now, if that person didn't disclose the fact that they use cocaine, think about that mood swing right there. Somebody went from looking manic, right, looking very stimulated and up and high, to feeling very depressed and anxious. Well, guess what? The withdrawal symptom from most drugs is the opposite of the effect of the drug. So the withdrawal symptom from a stimulant, for example, methamphetamine, crystal meth, cocaine, crack, even prescription drugs like Adderall, if the drug is a stimulant, which means it activates you, gives you more energy, and makes you up, the withdrawal effect, once you become addicted to it, is the opposite effect. So somebody who is in withdrawal from Adderall, for example, is not going to be able to get out of bed, is going to feel like, I can't get up, I can't get motivated, I can't get moving. All right? So when we're dealing with mental health diagnosis, we're really having to, in a way that, drug use is a pretty easy one because we can give a urine test, but you have to be thinking that way. You can get urine from somebody and see if they've been using any drugs. But a lot of times we ask people to be clean for 2-3 months before we can even try to diagnose them with a psychiatric illness. And so it's difficult. This is why I really encourage people not to try to diagnose themselves, because a lot of times you look at these criteria and you say, wow, that sounds like me, or that sounds like so-and-so that I know. But again, it's hard to know. You have to really look at the whole picture and think about the totality of the person. Also, just a really bad idea to try to diagnose somebody that's in your family or that you have a personal investment in, because what's going to happen is you're going to give them a bias one way or the other. If it's your kid and your kid does, really aggressive, irritable things, and is nasty sometimes and misbehaves, you may, for example, undervalue their behavior and say, that's nothing. I understand why he did that. And meanwhile, they have a psychiatric illness. On the other hand, if it's your spouse and they cheated on you and they lied about it, you're going to think that they're a sociopath, right? Because they really hurt you. All they do is lie. And the fact is the person only lies to you, right? That doesn't make him a sociopath. It just makes him a shitty husband, right? So, try not to diagnose people in your families and try not to diagnose yourselves. What you can do if you're having distress is to talk to your doctor. I mean, a lot of times if you have a primary doctor, you can start there. They can at least get you started or make a referral to you. If you have a doctor that you see anyway, it's the easiest thing you can do. But you can use the resources that I gave you. The bottom line is that there are treatment options out there. If you're feeling uncomfortable, if you're feeling like you need help with something, you need to seek the help out. There's no shame in it. So I hope that this was enlightening. I mean, I try to share the personality disorders, for example, are some of the most difficult ones because they don't do well with medications of personality disorders. It's hard to find treatment programs. Many practitioners have a hard time treating the personality disorders. In fact, I had one of the first people that I worked under was a nurse practitioner way back in 2003 that told me if you're sitting with a patient and they're pissing you off, they're probably a borderline personality. And, it's a mixed message what she gave me, because on one hand, she was telling me, listen to your gut, pay attention to what your gut's telling you, because that's important information to have. But on the other hand, I think that was kind of a too blanket of a statement. I appreciate where she was coming from, but, my wife and my kids piss me off sometimes too, but they're not a borderline personalities. I can guarantee it. So I hope that for some of you who are listening, who are in the field, I have given you a different way to look at some of these things. But for some of you this is more for those of you who aren't in the field, who may have curiosity about illnesses, who may wonder about the people in your family and why sometimes they get diagnoses that don't make a lot of sense. I hope that this has been helpful. Sometimes you can go to one practitioner and get one diagnosis and another practitioner and get another one. And in the vast majority of cases, it doesn't mean that either one was incompetent. Sometimes people can show up and feel depressed and get a diagnosis of major depression, right? But that person may indeed be a bipolar or may have a bipolar disorder. And what happens is many people who are bipolar don't complain about their manic symptoms because they don't feel bad when they're manic. They feel excited, energetic. They feel like they can take on any challenge and be successful. So that same person now will get the antidepressants from the doctor that they see, and they complain about the depression. The antidepressants kick them into mania, and a week later they're in the emergency room, or a month later they're in the emergency room, and their behavior is bizarre. They're screaming, they're getting aggressive. They think they have special powers. That's not a different illness. It's just presented differently, which is why it's important to rule out things, to, whenever possible, talk to family members. That's a tricky one too. Like I said, the same family member who could give you some good information can also give you some really biased crap, that's part of their own relationship problems. In any case, if nothing else, what I'm trying to drive home for you today is that bipolar disorder is one of those things that's found its way into popular language, and we use it to describe people very often that just are behaving in a way that annoys us. All right. But the illness of bipolar is actually kind of a serious one. I mean, it's one that can really influence people's lives and affect the way they behave and the way they function. And it's not, you don't just diagnose it willy-nilly. I mean, there's very concrete criteria that people have to meet. And a lot of times we need to pay attention to those things before we just call somebody bipolar. But anyway, guys, thank you for listening. I hope this was helpful. I hope that for those of you who are curious about psychiatric illnesses and how they're diagnosed, this gave you some insight. If you have any questions, as I said, reach out to me. I'm happy to answer them. My Twitter account is breakdownswithg@twitter.com. You can email me at breakdownswithg@gmail.com. Reach out to me. I'd love to hear from you. Follow my podcast. Share it. Tell your friends about it. I love seeing my download numbers. In this month, the month of April, my downloads basically quadrupled. There's my first month where I got over 1,000 downloads, and it's very exciting to me. I feel very, very proud about that. I thank you all for supporting me, for listening, and I hope that we can keep this going. I'm having a lot of fun doing it, and I hope you guys are enjoying listening to it. If you have a mental health problem, or you think you might, or you just want to get some information, go to SAMHSA.gov, SAMHSA.gov. It's Substance Abuse and Mental Health Services Administration website. There's a ton of resources on there. There's stuff you can read. It'll tell you where there's psychiatrists and counselors in your area. If you have health insurance, your health insurance card will 99% of the time have a mental health specific number on the back. Call it. Get a counselor. They'll tell you exactly who takes your insurance and where to go. And lastly, if you live in Central Jersey and you want to come out and visit the practice where I work, visit the website, BeWellNJ, BeWellNJ.com. It's a great practice. They take most insurances. Very nice counselors there. Speak English, Spanish. Come out. We would love to see you. Thanks again, guys, and take it easy.